and I have been told, Cheryl did an awesome job staying on time, and I've been told that I have exactly 20 minutes to start and finish this little talk. And so this is much shorter than I usually speak. So I cut this down from my Pain 101 talk to just strictly pain assessment today. And I'm hoping to get through it in 20 minutes very quickly. So don't be afraid to interrupt me if you have questions, and we'll get through it and there'll be time for questions at the end, hopefully. So why are we here? Our objectives are to understand what is called nociceptive pain versus neuropathic pain. They're the two sort of branches of the pain tree, and I think it's important that you have a working understanding of the two major types of pain. And then we're going to, of course, review the assessment of pain, which is what our talk is on today. So I have a few concerns. Whenever I talk about pain, I bring up a few of my concerns. The primary being the yin and yang of inappropriate pain control. What you're going to run into, and what our medical system does, is prior to people being end-of-life care, we are extremely chintzy using pain medications and treating pain. That, I feel, is inappropriate. We should be treating people's pain more aggressively and better. Then, when people come on to hospice or are deemed to be end-of-life care, all of a sudden, no one cares what you use, and you can use whatever you want. So in the hospital, we often have people that are not being treated for pain very well. They come into hospice and the doctor basically says, the nurses can use whatever they want to keep them comfortable. As if, well, if we shorten life with pain medicine, that's okay. We're just trying to keep them comfortable. So we have this early, inappropriate, low amount of pain management, and then this inappropriately aggressive, lack of understanding about using them at the end of life. And I think there's a liability. I was asked to review a lawsuit, and the lawsuit was based around a family suing a hospice nurse because they felt their mom suffered at the end of her life. And the basis of this was that there was this open-ended, wide-open pain order from a doctor that said 5 to 20 milligrams every hour as needed. And they argued that the nurses should have used 20 every hour to keep their mom comfortable. And because the nurse used less than they could, they were getting sued because the mom was felt to be in pain at the end of her life. So I think that we, physicians, nurses, nurse practitioners, all need to work together as a team to manage pain well. We need to have very specific orders to help protect all of us with patient care and how things go. So pain, most textbooks will define it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. I think what's important here is it is a physical sensory experience, but it's also a very emotional experience. Just ask my 6-year-olds. Every time they stub their toe, it is like the sky is falling. They just bawl like little babies. I'm trying to toughen them up, but pain is more than just a sensory feeling. It's an experience emotionally as well. So let's talk first about nociceptive. I'm going to make it work. I'm going to move side to this side a little bit. Keep things fresh. So nociceptive pain, when I teach families, I don't use nociceptive and neuropathic. I told them that there are two types of pain, regular pain and nerve pain. I think people can understand. We all understand what regular pain is. It's acute. My wife came upon a skateboarder yesterday who had come down a big hill, hit a curb, flew into the woods, and had a huge gash on his head where his helmet should have been. And so he had an acute incident or issue. He had pain. Pain is a protective thing. If I trip up here and break my leg, I have pain in that leg on purpose. We have a regular pain system on purpose to protect us. If I continue to walk on that leg, it would never heal. My body has me feel pain so that I stay off that leg and allow it to heal properly. So we have a pain system on purpose, and when it works regularly, it generally is affected by acute or quick instances. It can be protective, and we all know that we have a reflex system as well to help us prevent getting into pain. I touch the stove, and before I even feel the pain, my hand is already moving. This is a highly developed part of who we are. So again, I use the phrase regular pain when I talk to families. It is direct stimulation of intact nociceptors. Isn't that an awesome sentence? So our body has organs. We have our ear, our eyes. We have these sensory organs, and all through our skin, muscle, and bone, we have nociceptors that feel pressure, heat, chemicals. And these little receptors in our skin notice when there's a problem. When they get stimulated by pressure, I press on the wall, and I can feel right where I'm pressing, it transmits that signal along normal nerves up to my brain where I feel the pain. Generally, tissue injury is apparent. So that kid that hit his head last night, or me with the broken leg, you can go into the ER, the doctor says, look at that big swollen gash on your head. That's probably where you hurt. Or look at where his leg goes. That's probably where it hurts. Anybody watch basketball? Watch the tournament? Everybody knew where that kid's leg hurt because it went, oh, wakes me up. The point is, with regular pain, generally speaking, you can see where people hurt. You sprain your ankle, it gets red and swollen. It's often described as sharp, aching, or throbbing pain. And then I put in here for those of us that are in the, I don't do this when I talk to the public, but there's somatic pain, which is kind of on our extremities, where we can usually easily localize it. The kid's leg was broken, was at a 90-degree angle, and that's right where he hurt. That's compared to visceral pain, which is in our gut or our belly or our chest. Our body can define things very well. If you think about it, our body has to know exactly what we're touching and feeling as we move through our environment. But things that are internal, we've never evolved to have to be so specific. And so one example I give of this is when we have appendicitis, the typical course of appendicitis is vague abdominal pain, because at first our brain says, there's something going on down there. Something in my belly hurts. So at first it tells us, hey body, there's something wrong in your belly. Then it narrows it to your belly button, and it says, it's not the whole belly, it's a real precise area that's hurting, and then that pain generally slides to the right lower quadrant. So our body over time says, belly hurts, it's a small area, and it's over there. But it generally takes time for our body to put all those pieces together, as opposed to the broken leg. That kid knew right where he was hurting. Now let's compare that with nerve pain or neuropathic pain. This is felt to be a huge component of chronic pain. It can either be centrally, you have a stroke, and then you have a pain syndrome from your stroke because of something centrally, or peripherally, like diabetes. Our bodies have nerves like all the way down to our feet, and there are little teeny blood vessels that keep that nerve healthy. Diabetes affects those blood vessels, which then affect and damage the nerve in your foot, and you get tingling sensation, you get burning. You've all seen the commercial with the person's foot with fire on it. Our nerves are damaged peripherally from our diabetes. Again, neuropathic makes us sound important, but patients don't understand what we're talking about. So I told them that we have nerve pain, and this is a disordered central nervous system. Our nerves are not acting properly. It can be from compression. You have a tumor pushing on a nerve and compressing it. We can cut it in surgery. It can get ischemic, not get the blood supply that it needs. And it can have metabolic injuries like diabetes. The pain often exceeds the observable injury. People with diabetes will say, my foot is on fire. We look at the foot and we go, okay, crazy person, your foot is totally fine. It's not red, it's not swollen, it doesn't look like anything. It is not a tissue body problem, it is a nervous system problem. The nerve is sending a signal and we can't see where the real damage is. We describe it as burning, tingling, shooting. I tell people, imagine your funny bone. When you bump your funny bone, if a patient ever says descriptors that make you think of your funny bone, holy cow, this time is flying. It's almost 20 after. I have till 9:30, right?
Yes, you're fine.
Okay, so we're halfway. Got to get through this. So whenever you bump your funny bone, if someone's describing their pain, and it seems like that's the kind of pain they're describing, just think, wow, there might be a nerve component to this. So there can be nociceptive pain, that kid that broke his leg. There can be neuropathic pain from diabetes. Could there be somebody that has diabetes and falls and breaks their leg? Could we have both kinds of pain superimposed on each other? Absolutely. So nervous system, I talked about the organs in your skin, the nerve cells that bring the signal up to our brain. They're all through our nerves are receptors and channels. You may remember this back from school. And that's where our drugs try to affect that signal. So these signals and channels help that signal move very quickly up to our brain. And we try to manipulate those signals so that they don't get to the brain, we don't feel the pain. I often will tell people that if I break my leg and I use pain medicine to stop it, it's not that I've stopped the hurt, I have just stopped feeling the hurt. I've blocked the pain signal so I don't experience it anymore. So we're talking about pain assessment and particularly communicating it with others. So with any symptom, whether it's nausea, pain, shortness of breath, subjective report from the patient is the gold standard. We can't, no, I'll wait till I get here. We have to talk to the patient and they'll tell us how they're feeling and we have to take it at face value, otherwise we're going to do patients a disservice. There's no objective measure that's as good as patient report. I often get asked, are vital signs useful? Do you think vital signs are useful? I got a yes, a yes, a no. Some people ignoring me. Oh, can be. Perfect answer. Perfect answer. So the reason that it can be is our body has a fight or flight response, a sympathetic nerve response. So when that kid fell and broke his leg, his body got into this fight or flight mode, and his blood pressure and pulse, I guarantee you, sitting on the side of that court, were elevated, as well as every other person in that stadium and me watching on TV. Certainly, his vital signs were changed. But that change goes away quickly. Our sympathetic nervous system, at some point, says, this is a chronic deal, I'm not going to respond to that anymore. So what I hear nurses call me and they say, I called Dr. So-and-so and said the patient in the nursing home was in pain. I called the doctor and the doctor asked me for their vital signs. And when I gave them normal vital signs, they said, they're not really in pain. That's not true. Chronic pain may not have any useful vital sign changes. Acute nociceptive pain certainly can. That was my stomach, for those of you that heard that. Didn't hear it on the video. Pretty loud. So this is the most important part of this talk today, is how we communicate about pain. There are 5 things that we need to know. And I use this little joke about me driving home from work, and my wife calls me and says, hey Todd, pick up bread on your way home. And then I say, white or wheat bread? And she says, wheat bread. And I say, butter top or not butter top? And she says, butter top. Big pause. And then I say, sliced or not sliced? So we go through all these things. Now, if she would have called and said, Todd, I want you to pick up some butter top wheat sliced bread on your way home, that would be a very effective, quick communication. I bring my marriage into a lot of my talks, so don't show her this video. So the 5 things that we need to communicate are about location. That's fairly obvious. They have abdominal pain, or their leg hurts, or their back hurts. We're going to talk a little bit about severity. How bad is it? How are they describing it? Do you have a sense of what kind of pain it is? What's the temporal profile? I'll go over that in a minute. And then lastly, what are the effects of the medications? So their back hurts. It's 10 out of 10. They say that it burns and tingles and kind of radiates down their leg. The temporal profile, it's worse in the morning, it's better in the evening. And what has helped? Well, they take ibuprofen and that's helped a lot. That gives me a ton of information. Or they've tried oxycodone in the past without any relief. Because if I spend all this time doing the math and figuring out what dose of oxycodone to give you, I call you back in 10 minutes and say, give them this oxycodone, and then you say, oh, they tried that last week and it wasn't effective. Well, we've just wasted 10 minutes of both of our time. So I want to know what has helped or hurt this in the past. So severity, we're all familiar with these scales. There's all sorts of different scales. Most people use a 0 to 10 scale. All scales have weaknesses. And I want you, that's a crucial thing you understand, is nothing is perfect. This is not what people look like. This is generally used for kids and they point at how they feel. And sometimes we use words. I had a woman in the ICU who was having this horrible pain. And the staff were really frustrated with her. And I sat down and I said, what is your pain on a scale from 1 to 10? She said, oh, it's a 7. And I said, after you get your medicine, is it better? She said, yes. And I said, so after your medicine, how bad is it? She said, 8. So I sat down and I explained the scale to her again. And I said, tell you, let's use words. I said, is it no pain, mild, moderate, or severe? She said it was severe before she got the pain medicine, and it was mild to moderate after. This is a woman who could not comprehend a 0 to 10 scale. I heard this number somewhere, I don't know where it came from, but 17% of our population cannot extrapolate a subjective feeling to an objective number. You know, my kids have trouble comprehending certain concepts and certain constructs of how to think. We develop those over time. some people don't get to the ability of being able to do a good job of extrapolating. Also, sometimes chronic pain people have realized that if they say their pain is better controlled, their doctors stop all their medicines that have been helping. I had a patient in the hospital whose pain was an 8 out of 10. She could not move in the bed. We made some adjustments, and the next day she was sitting up, having something to eat. Said her pain was an 8 out of 10. The next day, we adjusted things. The next day she was up walking in the hallway demanding to leave. I asked her, what's your pain? An 8 out of 10. Had JACO came in and looked, they would have said, you had somebody come in with 8 out of 10 and you discharged them that way. What terrible care. I needed to make sure that I communicated with everybody that this woman, 0 to 10 scale, is not very effective, and I'm going to base my care on her activity and functional level because that seems to be the best predictor for her. If I would not have communicated that to everybody, they would have kept using that scale. Just like the woman in the ICU. If I didn't say to the next team, or the nurses didn't pass on, hey, the 0 to 10 scale for this lady is useless. You need to use these 4 words to help it. We would have done all that work and figured that out on the first day, and then 8 hours later when a new shift came on, we would have been back to 0 out of 10 useless scale. So we want to figure out what scale is best for people, why are we using it, so we can move forward. There's other methods. If someone can't communicate with us, they're just kind of moaning and groaning in bed, we put our eyes and look at how people are acting to give us a sense. Family does the same thing, and we need to trust the family. If family says that they're in pain, I say, tell me what you're seeing. Because if I walk in and they look comfortable, the family might say, but see how dad's holding his arm on his side, a little tense? That's what he does when he's hurting. That's good information for me to know. They know people better than we do. A lot of people put on a good face for the doctors and the nurses, and the family steps out of the room and says, he's really hurting, but he's not going to say anything to you about it. So we need to engage families and trust what they say. There's all of these other scales, the PAINAD scale, the FLAC scale. They were designed for very particular populations. I believe the FLAC scale is particularly used for pediatrics, and a lot of hospice programs have adopted that as their pain scale. It doesn't really make any sense unless they're a pediatric hospice. The PAINAD scale is particularly for dementia. The important thing to understand about all these scales is that they are one piece of the puzzle. They are not the Bible. If I go in and the PAINAD score, the nurse says the PAINAD score says it's a 2 and their pain is pretty well controlled, and I go in and the family says, but see how he's holding this, I think he's in a lot of pain. We have to understand that these are all just a piece of the puzzle and they all have significant weaknesses. So people that have the inability to rate, we all do the best we can, but we need to document why and how we made the decisions we made, and there are learned behaviors like the chronic pain patients. So pain quality, again, that burning, stabbing, aching, sharp radiation question. If you called me and said, I think this patient's having neuropathic pain, I would say, pretty advanced, that's pretty impressive. You could also say, it's kind of, they said it's sort of burning and it kind of radiates down their leg. That's the descriptors that help me and you understand this might be neuropathic pain. Temporal profile, so I got to speed up, I have minutes left. There's no time for questions until that 20 minutes. So there's constant pain that kind of waxes and wanes, but it's there all day. There is constant pain with these episodes of breakthrough. So I'm doing okay, and then I have to go to the bathroom. I'm up for a while taking care of the kids for 2 hours after school, and my pain just goes through the roof until I get more help and I can be resting more. And then there's intermittent pain. This type of pain is generally bone pain from cancer spread. So people that have bone pain, when they're lying on their back in bed, off their skeleton, their pain is pretty easily and well controlled. They get up to pee, put all their weight on their skeleton, the bones rub together, and their pain goes from 0 to 25 on a scale of 10. That's what patients do. And then when they get back in bed, it's almost gone again. So again, temporal profile means how does it act over time? Osteoarthritis generally is best in the morning when you've been off your joints, and it progressively worsens as the day goes on. Rheumatoid arthritis has stiffness in the morning, and as you lubricate your joints, the day gets better and better as you go on. So somebody with arthritis in their joints, simply knowing how it acts throughout the day gives you a huge guess as to what might be causing it or contributing to it. So again, location, severity, quality, how it acts over time, and what has worked. If a nurse calls me and says, person's having abdominal pain, that's 9 out of 10, it's a kind of a stabbing pain, it's there all the time, and blah, 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 this has worked. Now I can ask some very pointed questions. We can get from point A to point B faster. When I'm going to tease Andrea. My last chance to tease her. When she calls me, she says, I'm with Mr. So-and-so and he has pain. And then there's this big pause on the phone. I'm driving in my car on my phone and I go, where does it hurt? Abdomen. Pause. How severe is it? My point being, if we want to communicate well from shift to shift and with other people in the medical profession, these are the things that we are going to be communicating about. 1 minute for questions.
Wow, good job.
You can just keep talking. The rest of this is boring.
It's a tie, isn't it?
Yeah.
Other questions? So, assessment is challenging, and we all need to do the best that we can. And there's a lot of pieces to it, and so it's important for us to communicate with each other. I really think a lot of people, like that woman in ICU, if we spent all that time, and the nurse and I figured out a better approach to communicating about her pain, and I didn't write it in my note, and she didn't pass it on to her next staff, all that effort and that huge breakthrough that we had would be lost. And we would be stuck in this quagmire of that woman's pain, continually. So, other questions? Or a question? Okay, thanks for your time.
Thank you.